excellent anatomical resolution with potential assessment of not only the subclavian artery, but other supraaortic vessels as well. In contrast, angiography with invasive hemodynamic measurement of subclavian lesions can also confirm the diagnosis. So, management of subclavian artery stenosis, potential modalities of treatment range from medical therapy alone to percutaneous interventions to surgical revascularization. The evidence for different treatment strategies is exclusively observational and retrospective. There are no randomized clinical trials to compare the efficacy of one strategy versus another. While some argue for conservative treatment with medications, most agree that in the setting of symptoms, including subclavian steal, claudication, or ischemic sequelae, surgical or endovascular therapy is indicated. So the indications for treatment include disabling upper limb ischemia, including claudication, rest pain, and digital embolization, vertebrobasilar insufficiency from Steele syndrome, anginal symptoms from coronary steal via IMA graft, leg claudication in the setting of axillofemoral grafts, and to increase flow before surgical procedures such as CABG using the IMA as an arterial conduit or creation of dialysis AVF. Indications for revascularization include arm ischemia, vertebral subclavian steal syndrome, coronary subclavian steal syndrome, and planned coronary bypass surgery using the ipsilateral IMA. Medical therapy for this condition, you should do medical therapy for atherosclerotic risk factors. This should be the standard care for all patients with any degree of subclavian stenosis. You can do antiplatelet therapy, aspirin, or clopidogrel if intolerant to aspirin, particularly in those patients with concomitant CAD. You can do lipid-lowering therapy with statins with a goal LDL of less than 100. You should do BP control using an ACE inhibitor or ARB. In patients with diabetes, you should do aggressive glycemic control with an A1C goal of less than 7. And in smokers, they should cessate smoking. Surgical repair includes axillary bypass. This has good long-term results with several studies demonstrating prolonged symptom relief with durable bypass graft patency rates. At 56 months, 75% of 16 patients were symptom-free with similar long-term graft patency rates. At 10 years, primary and secondary patency rates are 88% and 91% respectively. Carotid and subclavian bypass. This has a low mortality, low stroke rates, and good midterm and long-term patency rates at 10 years. And you can also do transposition of the subclavian artery. This is less commonly used. It does have a low mortality rate and higher patency rates. So endovascular interventions were first introduced in the 1970s with PTA being the first reported after successful intravascular interventions were done in other medium to large arteries. By the 1980s, several reports of PTA of aortic arch vessels appeared in literature. While balloon dilation of these stenoses was proven efficacious and safe, the major issue was need for reintervention. Long-term patency was much more inferior to surgical corrections. Other issues included cerebral embolization via the ipsilateral vertebral artery, subclavian angioplasty. In some cases, the delayed reversal of vertebral flow after subclavian PTA decreased this complication. Stenting and, in certain cases, distal embolic protection were later introduced to address some of these issues. When an intervention is indicated, a percutaneous approach is favored over surgical intervention in the current era of angioplasty and stenting. Subclavian stenting is characterized by proven efficacy and long-term patency without the need for general anesthesia, requiring shorter healing times and length of hospital stay, which can lead to significant cost savings per procedure. The technical success rate of percutaneous treatment for stenosis with stents has not been a significant issue. The success rates range from 91% to 100% have been reported in other countries. Success rates of treatment of total occlusions has ranged from 83% to 94%, and complication rates have been minimal. Peri-procedural deaths have not been reported. Stroke rates, including TIAs, have ranged from 0.9% to 1.4%, and major complications such as access site hematomas, distal embolization, and arm arterial thrombosis have been minimal. These statistical figures are better than those of surgery and justify the use of minimally invasive endovascular techniques for the treatment of subclavian artery stenosis. And that is all. Thank you very much. Does anybody have any questions?
Thank you, Dr. Boyd. Nice job. Any questions from the audience? Again, endovascular intervention at the subclavian level, you have two options. You can go from the groin, you can go from the arm. Advantage going from the arm, it's easier for the patient, and you don't have to worry about major issues with groin hematomas. The patients also can leave the institutions a lot faster. I typically use a 5-0 stitch to like a huge stitch or a figure-8 stitch from the skin. You don't need a closure device, and the patients do real hold pressure about 10 to 15, 20 minutes and wrap it up, and they go home. It's very gratifying to see the occluded artery reconstructed with stents, and they're doing well. As Dr. Boyd mentioned, the long-term pace is usually very good. So thank you so much. Nice job. Okay, let's conclude because we have one more presenter and we'll conclude the day. I think it's been a nice day so far, and we have even much more high-powered sessions for you tomorrow. If you can make it tomorrow, it'll be worth your time. Next presenter would be a consultant in neurology, Dr.Pascal. He is calling to us from Berkeley, West Virginia. He will be talking to us about early diagnosis of medical stroke.
Hello, I could play the presentation from my end.
Take it maybe once or twice a day.
Okay.
Once or twice a week.
Okay.
Actually, take this.
Dr. Tanger, go ahead. Dr. Tanger, continue.
Yeah, go ahead. We want to play from there.
Oh, okay. I get them on the stage.
Were you able to hear the presentation?
Yes, we were, yeah.
Oh, okay, good. Then I'll continue.
Continue.
Fragments, vision, all of this in the posterior circulation. Recognition of acute stroke symptoms for the general population can be done using the FAST acronym, which consists of balance, eyes, face, arms, speech, and time to activate emergency services. But for most providers, your patients are probably comatose or post-op. So for you in the audience that do surgeries, if you're suspecting a stroke in a patient post-op, you want to have your patient screaming. A scream is a good sign, but also a scream can help you determine true localization from a patient if they have major lateralizing motor or sensory deficits. They might be able to produce or not produce speech. You use the sternum, you use the nail bed, or even the glabella. Recognition of acute stroke symptoms is important when dealing with post-op patients. I'll discuss that here briefly. You want to look for speech patterns, simple commands, left and right differentiation. Posterior circulation is harder to identify. A patient might complain of nausea, vomiting, nystagmus, acting drunk. A quick finger-to-nose testing could clue you to a patient having a posterior circulation infarct. The dreaded locked-in syndrome presents with a patient's ability, with a patient retaining only the ability to blink. You want to recognize that and act immediately. Strokes are classified in severity commonly using the NIH stroke scale. Most hospitals have this, and this is how you communicate to a neurologist of the severity of the patient's stroke. I want to discuss a little bit of a transient ischemic attack, as this is more common than a full-blown stroke. Patients present within minutes, that present with symptoms that resolve within minutes or within 24 hours can be classified under a transient ischemic stroke. It's often a hard bind of worsening symptoms. I would like for everyone to use the ABCD score to determine, because most of the time I get a call asking, should I send this patient home? Should the patient be seen in the hospital? The ABCD score helps determine the subsequent risk of the patient having a worsening stroke. The stroke chain of survival and recovery is an easy 7-step process to bring quality care for a patient that has presented with a stroke symptom. We will go through all of these. Early detection is paramount to stroke care, and this depends on the knowledge of a victim, a family member, bystanders, and in the case of our audience here today, the medical staff. You want to familiarize yourself with some stroke symptoms. Detecting them early and activating the stroke chain of survival will lead to good outcomes. This patch goes without saying, activating EMS, or if you're in a hospital, you want to bring all hands on board to get this patient to a location or a person of interest who could manage the stroke. If you have no neurologist, do not panic. We all went through medical training, and I'm going to walk you through it. If a patient is not on site, rapid transport of a patient to a facility is required. We do our ABCs during all of the steps of getting a patient stroke care. I'll mention a little bit about airway insane. Some strokes are so devastating that they compromise airway. So those patients might need intubation. Do not hesitate to intubate a patient. It doesn't matter if they are having a seizure, a major stroke, or they have an acute coronary syndrome. Airway is paramount. And so is breathing, goes without saying. I want to note that hypotension and shock are rarely signs of stroke, so try to look for other cases. At this point, you want to be providing IV access, looking for seizures, evaluating hypoglycemia. And your best choice of IV fluids is isotonic fluids. DOOR stands for arrival at the emergency department, and this is where most delays take place, sometime in hours, given the chaotic nature of our emergency rooms. Emergency room physicians should be alerted to patients that have stroke symptoms so that diagnostic tests could be performed immediately. Again, ABCs should be reassessed at every chance. Number 5 is data collection. Again, I will beat it into everyone. Reassessing ABCs goes a long way to help stroke patients now obtaining CT scans and MRIs. You want to get the level of consciousness. You want to check for the type of stroke. In this, you'll be using CAT scan of the head to make sure a stroke is not hemorrhagic before you proceed with certain treatments. The location of the stroke comes in at the severity and the exact time of the stroke in centers where patients can get TPA. This is a CAT scan of the head, which can be obtained in under 5 minutes and can be read in under 1 minute by a trained specialist. What you see there is a dense MCA sign, which shows occlusion of blood in the right MCA, supplying the frontal and the parietal occipital lobes on the right side. This is a good reason why CAT scans should be obtained before giving any platelet or fibrinolytic therapy. This is not the image of a stroke that should be managed conventionally, as this is a hemorrhagic infarct. This is another important slide. The appearance of a hypodensity in the superior division of the right MCA here points to the fact that this stroke is probably more than 6 hours old. And this will not be a candidate for TPA. This stroke is prone to hemorrhagic transformation. You want to tread lightly, and you probably would want to transfer the patient to a higher level of care, as there is already a midline shift. Some centers have access to advanced imaging, where a patient can be evaluated for thrombectomy, which can be done within 6 to 24 hours from onset. At number 5, we discuss data collection, and this should be done from the moment a patient presents with stroke. What might look as a stroke is an unrecognized seizure. It could be a confusional state, it could be syncope, toxic metabolic factors. I just had a patient that had severe hypokalemia that presented with stroke-like symptoms. There is hypoglycemia, which is very common and easy to detect. And you might be the first person to diagnose a brain tumor in your patient who presented with stroke-like symptoms. Subdural hematomas. Decision-making follows data collection. Do we need to prevent aspiration by intubating the patient or making the patient NPO till such a time the patient can swallow safely? Do we need to treat hypertension? Do we need to treat hyper or hypoglycemia? Seizures or intracranial pressure in centers that can monitor such data. And number 7, we have to decide if a patient qualifies for TPA, which not every center has. This should be done within 3 to 4.5 hours of presentation of ischemic stroke symptoms. TPA, I would mention, given the population we deal with, has been beneficial in some patients with sickle cell disease. They will present with stroke-like symptoms. But again, there are some guidelines to follow for this. The NIMS trial found out that TPA will provide at least 30% or more of improvement with no minimal or no disability at 30 months compared to placebo. I would like to discuss blood pressures as they can be confusing when a patient presents with stroke. The ideal blood pressure in acute ischemic stroke remains unknown, but the general rule is that when it's a large vessel occlusion, you want to allow for permissive hypertension. Again, I said it was a plumbing issue. If there is an area of the brain that is not receiving blood, a higher blood pressure sometimes is the best treatment for a stroke that occurred within 24 hours. Lowering BP in hypertensive emergency and urgency by 15% is. For hemorrhagic strokes, you want to do the opposite, but avoid hypotension. For suspected strokes with no evidence of large vessel occlusion, normalize blood pressures. If a patient makes it to the inpatient unit, hopefully it's a stroke unit. If not, no problem. Supplemental oxygen should be started, blood pressures monitored closely, temperature, glucose, dysphagia screening, nutrition, DVT prophylaxis, rehabilitation, and please do not forget to screen for depression, as a stroke can be devastating. These are a list of modifiable stroke risk factors which you can undertake for your patients to prevent another stroke. Thank you so much for your time. And unfortunately, I will not be able to take any questions, but
thank you so much. I think so far it's been a really interesting day where we've had a few interesting case reviews as well as great talks from different speakers. Kind of all exhausted. I think we need to take rest up tonight and come back tomorrow for a really exciting day of endovascular technology cases and lectures. I'd like to thank our speakers, all our speakers today. Dr. Sanusi was graciously stayed here all day, and the other speakers that have spoken today. Our speakers, Dr. Larson from the USA, Dr. Bake, Peter, and Dr. Jeffrey Hager. We're glad that we're able to help us out with the conference this year. We want to say again, it's important as we go with this conference. The whole goal is to exchange ideas between professionals and also improve patient care ultimately. We have Dr. Veronica Oye who talked about the use of ultrasound technology, and it is up and coming. It's called point of care. When you have patients that need ultrasound intervention, ultrasound may be the first step. That would make their treatment a lot easier. You want to put center lines in, center lines there. More importantly, center line, you don't move around with lots of wires and cables. It's right there. So that's a good thing to have. So hopefully we've got members of our medical community here will invest in the technology. I think it's worth it. We also feel that this conference gives opportunity for our young medical students and residents to become part of a major vascular conference, and also keeps them sharp. We're excited about the presentations of all the presenters today. They all did a great job, and we're looking forward to having a great day tomorrow. And the 6th annual conference next year. We have some of our presenters and others come to Lagos, so have a great time here. And should anyone Nigerian Lagos hospitality is all about. Thank you very much. Let's see us next tomorrow. For those who are still here, if you still want to have something to eat, we'll just then go over to Regent. Have some. Thank you so much. And for others on the international stage, thank you very much from Bentley. We appreciate your patience and time today. And worldwide, Dr. Kusaya, thank you so much. And we'll see some great speakers tomorrow. Please don't miss it. Thank you so much. Yeah, for sign out, they call it sign out just because. Okay. And IT did a fantastic job. Thank you so much. No problem. Okay. All right, thank you. Photo session? Thank you so much. Oh, yeah, you can. Thank you. No worries. We'll collaborate and let her already. There's all those cables in the hospital. We're getting so cardiovascular surgery back then. We're walking around that ultrasound machine like that. Go like this. That's my briefcase. That's why it's a good idea. And, you know, I think it's a good opportunity for us to collaborate and leverage. So we'll go over to move down the street. That's less than a block here. And the person wants to have dinner. If you want to we'll go. Do it. Very good. Okay. Yeah, please sign in the book so in case we need to give you a credit. Thank you very much. Thank you. Great job, nice job. Appreciate it.